where I can see the list of participants and everything.
Sorry?
Usually there is a panel that appears in the on the top column wherein I can see all the participants and the questions. I'm not able to see.
Yeah, still you can see. Go on attendee list.
How do I get there?
Or you are using laptop.
Yes.
On right top of the corner there are a few lists. You are not able to see. Wait. Are you able to see any chat? I have text you now.
No, I'm not able to see. I'm just trying to see. No. How basically where does it come? On the tops. It used to come on the top.
On
right?
the top there are few options. Red. Are you able to see the red line?
Yes, yes. Now I can see, I think, yes.
Yeah.
So there is a chat, there are few participants as well. Okay.
Yeah, Dr. Preeti, it's 7:30. I think you should have started this session now.
Okay, thank you so much. Yeah. So, good evening, everyone. I warmly welcome you to today's session on pubertal disorders. I would like to thank the NBE for giving me this opportunity to be a part of this session. So, without wasting much time, I would start with my session on pubertal disorder. So, on the first slide, what you can see are the characters from Strange Things, right? So these are all the characters, and we have seen them evolve right from their childhood to their puberty, right? So I thought this is worthwhile mentioning on today's topic, because today we'll see how children mature during their pubertal years, during their adolescent years, and what kind of problems these children can have during their adolescent. Okay, or the pubertal age group. I have kept my video off because there could be some, network issues. So to have a good streaming of the network, I would like to just utilize the platform for the audio and the streaming of the slide presentation. So in today's presentation, we'll go through the definition and physiology, the stages of puberty, as well as a few case vignettes on the pubertal disorders. So going on to the definition of puberty, so puberty is actually a transitional phase from the childhood to adulthood and involves the development of the secondary sexual characteristics and attainment of the reproductive capacity. Now, there are a few definitions which I would like you all to understand. There's something called as gonadarchy, pubarchy, or adrenarchy. What is menarchy, thelachy, and spermachy? So, just to give you a brief outline, so gonadarchy is the development of the gonads, and it involves the production of the sex steroids, which ultimately would result in the changes, the pubertal changes that will happen. Then pubarchy is the development of the pubic hair, whereas adrenarchy is the biochemical change. Okay, so whenever we have the production of the androgens from the adrenal gland, then that particular phase is called adrenarchy, and adrenarchy leads to the development of pubic as well as the axillary hair. So pubarchy is one of the clinical manifestation of adrenarchy. Menarche is the onset of the menstruation. Thelachy is development of the breast bud, and spermachy is actually the presence of the spermatozoa in the seminal fluid. So all these definitions which we'll keep using during our today's presentation. So it's very important that we are well versed with these definitions. Now, the major changes of puberty that happen are the physiological, metabolic, as well as psychological and emotional changes. So, during adolescence, it's actually a period of turbulence wherein a lot of changes are happening, which involves the development of the gonads, the maturation of the reproductive organs, the result that actually results in the presence of secondary sexual characteristics. An important component of adolescence or puberty is actually the growth spurt. So we all experience this kind of a growth spurt, the increase in the height velocity during puberty, and it is one of the phenomenal or the key component of puberty. Then there are a lot of changes in the body composition, the distribution of fat, and increase in the musculature and lean body mass, as well as bone mineral accretion that makes this phase extremely important. And it is very important that we all undergo puberty very normally and at the appropriate time so that all these changes are well accustomed by us. Now, just a brief overview on the physiology of HPG axis. So, what happens is that there are some central signals as well as peripheral signals. The central as well as the peripheral signals, they actually impinge upon the GnRH pulse generator. Okay, so GnRH pulse generator leads to the production of the GnRH, that is gonadotropin releasing hormone from the hypothalamus, and there is a specific area in the hypothalamus, that is the arcuate nucleus or the medial basal part of the hypothalamus, from which the gonadotropin releasing hormone is released by either the central or the peripheral signals. Now, once the GnRH hormones they start releasing from the hypothalamus, they act on the pituitary, which leads to the production of the gonadotropins in the form of FSH and LH. And these gonadotropins then further act upon the gonads, that is the ovaries in females and testes in males, to produce the sex steroids in the form of estrogen and testosterone, which ultimately give rise to all the pubertal changes that happen during adolescence. Now, what we need to understand is that the action of the gonadotropins is different on the gonads. So, when we have the production of the FSH acts on the Sertoli cells in the testes, and it acts on the granulosa cells in the ovaries, right? So what happens is when it acts on the Sertoli cells, it leads to the maturation of the, it actually leads to gametogenesis and also increase in the size of the testes. While on the granulosa cells, what happens is that it acts on the follicular cells to lead to the production of estradiol, which is responsible for the production for the thalak phase of the puberty in girls. While LH, what happens to LH is LH acts on the Leydig cells in the testes and the theca cells in the ovaries. So when it acts on the Leydig cells, it leads to the production of testosterone, and this testosterone is then responsible for the secondary sexual characteristics in the male. So we should be well versed how these gonadotropins they act differentially on different cells in the gonads for the production of their secondary sexual characteristics. Now, what is this GnRH pulse generator? A small brief overview on this pulse generator, because this is the important part that we need to understand, that is the regulator of puberty in our body, right? So this GnRH pulse generator, when it gets activated, and there are a lot of peripheral as well as central stimulators that actually leads to the activation of the GnRH pulse generator. And during childhood, we should all be aware that during childhood, the GnRH pulse generator is in the quiescence phase, right? So there is no activity of the GnRH pulse generator, and hence there is no appearance of the secondary sexual characteristics during the childhood, which could be in the form of thalak, or it could be in the form of increase in the testicular size or the penile size. So when the GnRH pulse generator gets activated, and this has a very important role in the changes of puberty that happens during adolescence. In fact, the timing of puberty, it has a very strong genetic influence. So for children who come with delayed puberty, sometimes it can have a genetic predisposition that their parents had also attained puberty at a later stage. So timing of puberty has a very strong genetic influence, and there are certain nutritional and hormonal factors. Remember that nutrition plays an important role in assuming the role of the GnRH pulse regulator, because once the children who are having undernutrition, they usually have a delayed puberty, while children who are having obesity, because the fat mass, it actually determines the or activates the GNRS pulse generator. So children who are having a rapid weight gain, specifically in the age group of 8 to 10 years, they are bound to have a accelerated or early puberty. Similarly, environmental factors like stress, visual olfactory stimuluses, or some environmental disruptor chemicals in the form of bisphenols, or sometimes we have seen that children who are exposed to these kind of environmental disruptors, they can also have early or delayed puberty. So we must understand that GnRH pulse generator is the key regulator of the puberty in our childhood, and once it gets activated during puberty, the line of the line of particularly the events, it actually starts. So during the neonatal phase, very important to understand that during the neonatal phase there is something called as mini puberty, and because the GnRH pulse generator is active during, say, from the age of 2 weeks up till the age of 6 months in boys, and in girls it remains activated up till the age of 2 to 3 years. So the activity of the GnRH after the age of 2 to 3 years, it goes in a quiescent phase, the juvenile phase, till there is a relinquish of this GnRH inhibition, and then that leads to the activation of the pubertal changes that manifests as the adolescence, during the adolescent phase. So we have already learned that genetic and environmental factors, they play an important role in causing the early or the delayed onset of puberty. Now, what are the stages of puberty and how do we really evaluate for them? So puberty, it consists of a series of predictable events, and these events are actually characterized as sexual maturity rating staging or the Tanner stages. But what we need to understand is that every child undergoes this progression of puberty, and the steps, the categorization of the stages of puberty for it's very important, because we need to understand that for each sex the staging is carried out in the following steps. Like we have the stage B for breast development, and P, that is pubic hair development for females. Similarly for boys we have the genital stage G, which actually categorizes the development of testes as well as the penile gland, and P, that is for pubic hair for females. And similarly, we have the axillary hair, that is denoted by the symbol A for both males and females. And the SMR stages, they progress from stage 1 to stage 5, that is stage 1 is prepubertal, while stage 5 is the adult, and 2 to 4 are the other pubertal stages. Now, in girls, the first sign of puberty is actually thilark. Okay, that is the appearance of the breast bud. While in boys, the first stage of puberty is the increase in testicular volume, which is denoted by the stage G2. So whenever we have a appearance of the breast bud in females, we call it as thilark, which is denoted by B2, while in boys, the testicular enlargement is denoted by G2. Now, it is important to understand that there is a very important role that we need to see that what is the timing of puberty, how the sequence of pubertal events follow, and what is their temporal relationship with each other. And adolescents can also be in different stages of maturation in any of the two pubertal characteristics. But what we need to remember is there shouldn't be a difference of more than one stage in relation to P when you are talking about breast development, and in relation to G, genital development, in relation to the pubic hair development. So the events, they happen temporarily and they follow a predictable sequence. Yes, it can vary. Is termed as precocious puberty in females, while anything which happens before 9 years in boys is called as precocious puberty in males. So once the pubertal development starts, that is the lark happens, what usually follows it is the development of pubic hair at an interval of 6 months to 12 months. This is then followed by a high spurt, which usually happens in early phase of puberty in girls, and then around 2 to 2.5 years later, there is onset of menarche. And once the menarche happens, the pure growth velocity, it comes down, and this is then followed by the fusion of the epiphysis at around 16 years. The genital stage, that is the enlargement of the testes to a volume of 4 ml. Now, once the testicular enlargement starts, there is production of the testosterone, which leads to increase in the size of the penis, as well as there is increased pigmentation of the scrotum and thickening. This is again closely temporally related with the appearance of the pubic hair and the axillary hair. But what is important to understand is that as compared to girls, the height spurt in boys, it happens usually in somewhere around B. When we are talking in terms of G stages, it is somewhere around G3 to G4, while in girls it is happening somewhere between B2 and B3. Okay, so it is early in girls as compared to boys. Boys may the puberty is happening somewhere around in the mid stage. Okay, so this is actually at the stage of G3 and G4. Now, pubertal assessment in girls, very important, is how to assess the breast size. Now, breast is what is important is that we need to understand the difference between lipomastia and thylac, and this can only be done by palpating the breast tissue and not just visually examining the breast. So often we make the mistake of visualizing the breast, and often we miss the stage B2, that is the appearance of the breast part. And for this, we have to use our forefinger and thumb and try to squeeze the tissue between the thumb and forefinger in a sitting posture, which is considered as the best technique to palpate the breast. So it is very important, specifically in obese girls, wherein lipomastia can be mistaken as breast stage B2. Okay, so palpation of breast becomes very important component in the evaluation of puberty. And as we can see, flatus B1 to B5, these are the Tanner staging, though B1 is the prepubertal stage. So that means that there is no breast tissue that is palpable. And once the breast tissue starts getting palpated, that becomes B2, and this is called as thylac. And the accelerated growth spurt is happening between B2 and B3, and after B3 we have the onset of menstruation, which is called as menarche. And you can see that B5 is considered as the adult or the mature form of the breast development. Temporarily associated is the pubic hair development. So P1 is no terminal hair or the no pubic hair, and when you have sparse or some amount of pubic hair which can be visible is called as P2. Once the pubic hair becomes thickened and darkened, it becomes P3. Between P4 and P5, you can try and differentiate between the two stages by looking at the distribution of the pubic hair. So when you have the pubic hair which are good in amount, good in texture, pigmented, thick, coarse, and it is sparing the medial part of the thigh, that is considered as P4. So once the pubic hair, it occupies the middle part of the thigh, that becomes P5. Now, this is a very important slide. Why? Because puberty is associated with the bone age acceleration. Okay, so what we need to understand is that the bone age correlates with the stage of puberty rather than with the chronological age. And so very important that for children specifically having early puberty or precocious puberty or delayed puberty, that we do a bone age assessment to see whether the bone age is also accelerated or not. Okay. Then, when we have the production of the sex steroids, obviously there is maturation of the internal as reproductive organs like uterus, ovaries in girls, as well as thickening of the endometrial tissue, and so this can all be evaluated using an ultrasound pelvis to see what are the different phases that or specifically what are the different changes in the size of the uterus, the endometrial thickness, or the size of the ovaries to see whether it is really pubertal or not. Then in boys, when we assess puberty, what we need to have is a scale and a Pladder's orchidometer. Now, this Pladder's orchidometer help us to understand that and also evaluate the size of the testes. As we all know that the first sign of puberty in boys is the testicular enlargement. So anything more than 3 ml is considered as testicular volume. More than 3 ml is considered as pubertal, and this is first discernible sign of puberty. Now, along with this increase in the testicular volume, we have other changes taking place in the external genitals in boys, like increase in the penile size, then as well as the width. Then there could be spermachy, then there is growth spurt, there is breaking of voice. So all these changes are also accompanying with the physical features. Now, this is the pictorial representation again, which is depicting the Tanner stages from G1 to G5. So, what we need to understand is that we don't call staging as stage 1, stage 2, stage 3, or stage 4. We need to understand that we have to individually measure the size of the testes, both on the right as well as the left side, as well as the measure the size of the stretched penile length. Okay, so because both the things have, though they go common, though they go hand in hand, but there could be some differences in the that we will not be able to categorize well, because it could be possible that testes in is particularly somewhere measuring say 6 ml or 8 ml bilaterally, while the SPL would be somewhere around 5 centimeters or 5.5 centimeters, because there is a lot of variation between children, right? So individually measure the testicular volume as well as the SPL, rather than calling it as stage 1 or stage 2 or stage 3. Okay. Now this is a Prader's or chirometer. So what you need to do is you need to compare the size of the testes with the Prader's or chirometer and see what size it actually matches, so as to categorize it as 4 ml, 5 ml, 6 ml or 8 ml or so on. Then pubertal growth is also evaluated by measuring the SPL, so stretched penile length, and for this we require a ruler or a spatula. What we need to understand is that the one end of the spatula is kept at the pubic ramus or the symphysis, and the other end we stretch the penis up till the glans, and we try and measure the size from the pubic ramus up till the glans of the penis, right? And excluding the foreskin. That is very important. And we have to individually measure the SPL and then mention it in the records, so that we know the progression, the baseline record as well as the progression of puberty. Again, in boys, remember that the growth velocity happens a little later as compared to girls. In girls, it was happening between stage 2 and 3, while in boys, it is happening between stage 3 and 4. And again, the pubertal stage, it correlates with the bone age more than the chronological age. Now, this is just a small case which will help you understand how does the height changes that happens with relation to the puberty. So we have a case A where we have a girl which is 12 years old and is in SMR stage 2, while another girl again with 12 years and but in SMR stage 4. Now the parents would like to know, both these girls are of the same age, but they are in different stages of puberty. One is SMR stage 2 and the other one is SMR stage 4. So the one who is in SMR stage 2, we know that growth spurt is expected shortly. So whatever the height the child has at 12 of age, the child is now bound to experience the growth spurt. Obviously, the height potential would be more in case A as compared to case B. Why? Because in case B, the growth spurt has already happened because the girl is in SMR stage 4. So whenever we are, in the OPD practice, we are seeing patients, we are seeing and, evaluating the height. Make sure that you note down the SMR stage of that particular child, because the height potential of that particular child will actually depend upon the pubertal stage. Okay, so the one who is in SMR stage 2 will have, obviously is expected to have the growth spurt shortly and will definitely have a better height potential as compared to the one who is coming already in stage 4, because that girl has already experienced the growth spurt. So obviously you don't expect much of the growth to happen after stage 4. Now, again, the same thing which I have just depicted in the form of a flow chart. So whenever you have a girl or a boy who has been brought by the parents and parents are really concerned about the growth of the child, please make it a point that after the age of 9 to 10 years, do SMR staging and assess whether what stage of puberty the child is in. The child is pre-pubertal or pubertal, and if the child is pubertal, then which stage of puberty the child is actually in which stage of puberty the child is lying, because the growth potential actually depends upon the stage of puberty. So if you have a child who parents are worried about growth faltering, but the child had a normal onset of puberty, then this child could probably be having familial or a short stature. The one who already had early puberty, so this could be a case of precocious puberty, while the one who had not experienced puberty at this point of stage, this child has better height potential. And why? Because the puberty has not occurred up till now, but however the child is short, so we need to evaluate. So the causes or the etiology for this kind of scenario would be either constitutional delay or systemic causes, endocrine causes, or hypogonadism. So all